Good morning. Hello, everyone. Thank you for attending today's webinar. Payers Need to Rethink Modern Business Model and Focus on Impactful Transformation, presented by Fierce Healthcare and sponsored by Citius Tech. I'm Rebecca Kushmiter, and I'll be moderating this webinar. I'd like to start by introducing today's speakers. We'll be joined by Paul Mango, former Deputy Chief of Staff for Policy at U.S. Department of Health and Human Services, and Shyam Karukaran, Senior Vice President and Market Head of Health Plans at Citius Tech. You can read their full bios on the left side of your window by selecting the Speakers tab. Now, just a few notes before we begin. To access additional resources for today's presentation, please click the Handouts tab button on the left side of your screen. You can access closed captions from the bottom right corner of the video player. This webinar is being recorded. It will be available to watch on demand within 24 hours. We'd love to hear from you. During the presentation, please submit any questions you have using the Questions and Answers tab on the left side of your screen. And time permitting, we will conclude with a Q&A session. Okay, now let's begin. Gentlemen, please go ahead.
Thank you, Rebecca. First of all, to the Fierce team, thank you for having us. It's great to be here and also have the platform to share our thoughts with the audience over here. Also, Paul, thanks for joining us. It's a privilege to be talking alongside you, align on our thinking and thoughts. For the rest of the team, Paul has been advising Citius Tech on many things across all parts of our business for close to 2 years now. So it's been a privilege working with Paul. Before we get started, let me just take a quick 30 seconds, a quick preamble on today's conversation or talk. Paul and myself, we have tried to be a bit intentionally provocative because we do believe that the healthcare industry today is at a really good inflection point to truly retrospect on some of the growth strategies and forward-looking focus areas. So the document and the presentation is a little bit opinionated, and we truly look forward to hearing some feedback from the team who is listening to the webinar today. So on that note, Paul will be covering the initial aspects. Paul, over to you.
Thanks, Shyam. Appreciate it. And greetings, everyone who's joining us this morning. Here's the agenda for today. As Shyam alluded to, we're going to offer a provocative point of view about recent growth strategies that some of the big health plans have pursued, and then talk about some of the disruptions that have emerged, particularly in the last 6 months or so across many of their insured segments and also their PBM. So we're going to talk about that. Then give a little bit of, what does Wall Street think about this? And I think our overarching point of view is that current performance is very strong, but long-term health of that performance may be challenged by some of the disruptions. And then Shyam is going to take you through, on top of the regulatory and legislative disruptions, what role technology could be playing also in future emerging disruptions. And then we're going to end with our point of view on the way ahead, just a few thoughts on how you might wish to navigate some of these disruptions. So that's the agenda for today. And we're both going to be posting, when we're done, we're going to be posting kind of a white paper on both of our LinkedIn sites, my personal one as well as the Citius Tech one, where you can read more about this. For those of you who can't stay on the whole call, you can read some of that. So here we go. And again, we're trying to be intentionally provocative here, but if you look at the last 3 to 5 years and the growth strategies that a lot of the health plans have pursued, we think there's 3 reasons, and this is really the first one. Expanding addressable market to fill expectations that the price earnings ratios have imputed in them. So if you have a price earnings ratio of 18, 20, 22, which some of the carriers have had in the last few years, and you look at the core health insurance business, it can't grow fast enough to fulfill those expectations for growth. So what we've seen is a lot of the carriers have diversified into analytics, into provision, into wraparound services for value-based care, very successfully, by the way. So we're not contesting that at all. We're saying one of the motivations for doing that is really that the core health insurance business, beyond Medicare Advantage, and I think in the short term, the ACA marketplace, there just hasn't been much growth, particularly when you think about Medicaid redeterminations and a few other things. The second reason is really the constraints that the minimum loss regulation or minimum loss ratio regulations have imposed on payers, 80% in the individual market, 85% in the group market. And if you own a provider organization or you own a PBM, just as an example, you charge a small group risk client 100% or $100 for a drug. You get rebates. You share a good part of that back, but you keep 5% of it. The total $100 goes toward MLR, but the $5 rebate you're getting in your PBM doesn't. So it's really an interesting way to, if you will, ease some of the constraints of minimum medical loss ratios imposed by the ACA in 2010 when that was passed. And then I think the third reason, and the one we probably feel is most challenged right now, is creating these chronic disease management platforms or whole person management platforms. And again, in isolation, they seem to be creating a lot of value in terms of lowering cost, improving outcomes, improving patient satisfaction. The real challenge is aligning them with one's own membership. And we think that's where the real challenges and struggles have emerged. So to the extent the street and the investors thought that there'd be, a 300 or 400 basis point reduction in one's Medicare Advantage book, but you're only covering 5% of your own members with your own platform, it's just not playing out the way it was originally anticipated. So we're going to spend a little bit of time on that. Anyway, this is what we would suggest have been the primary motivations for growth over the last, again, maybe 3 to 5 years. If you talk about, some of the complications associated with that, particularly prospectively, one is as the denominator grows, the ability to diversify and still meet those growth expectations becomes, again, more challenging. We have probably participants on the webinar today whose organizations are north of $300 billion of revenue. To grow 10% means $30 billion. You can do the quick math. And a lot of that has been done through acquisitions over the last several years. That will be challenged by the current FTC. But even more important, there's not that many large acquisitions left. So one question would be, how much runway is there prospectively associated with big acquisitions that can propel growth? The second one is what I alluded to just a minute ago, which is aligning the captive membership with the captive provider assets. None of the large payers has really gotten above 20%, and even that is stretching it a bit. A lot of them are down below 10%, meaning if you have primary care, pharmacy, and home care assets, and you want your own members, in this case Medicare Advantage principally, to use them, they're having trouble. These carriers are having trouble getting above kind of 10% of their members flowing through their own platform. So we think that's going to be a challenge. And then channel conflict and other strategic complications. So basically what a lot of the large carriers have become is what we would refer to as bilateral open integrated delivery networks. Well, what does that mean? It means as payers, you're contracting with your own captive providers, but also many others that compete with them. And as provider, your provider assets are all payer agnostic, meaning they're actually contracting with competing health plans. And that does create complications. And in some of my travels around the country, when I talk to providers about who your biggest competitors are, it's no longer the provider down the street. Oftentimes they answer, it's a big health plan that's invested in ambulatory surgery centers or urgent care centers, or certainly large physician practices that they've acquired. So that creates some what we call channel conflict, and causes the providers to rethink that relationship a bit. So again, growth strategies that were motivated on the previous, on the left-hand side of the page, I should say, by 3 factors, and now the carriers are encountering some complications associated with that. Let's add to that the legislative and regulatory disruptions that we've seen emerge, in the last several months, certainly the last 12 months. I think probably the biggest ones, if you're a Medicare Advantage player, is the risk adjustment model changes. And some of the statements in the recent earnings calls would suggest that the carriers are much more concerned about this than they are about temporary spikes in utilization, for instance, which we saw in May and in June. And CMS has obviously eased this change a bit because they're implementing it over 3 years, but nonetheless could have significant impact on profitability and performance. Again, Medicare Advantage. Star rating adjustments, same thing. A lot of changes have emerged. One of the biggest ones is the Health Equity Index, which basically is added as a star criteria, which will encourage Medicare Advantage carriers to ensure they're reaching down into the socioeconomic strata to have a certain percent, if you will, of folks who are more indigent in their MA plans. And there's a lot of MA plans today and H contracts that simply don't have that number. The median across the country that CMS is looking for is 41%. And again, many carriers aren't there. So they could risk their 3.5 or 4 or 4.5 star rating with that change. Medicaid redetermination, we think it's going to have impact on 2 principal segments, maybe even 3, maybe a little bit on commercial. A lot of people go back to their commercial plans, but principally managed Medicaid will decline. It's already happening. It's happened since the 1st of April when the redeterminations have started. A lot of those folks will go to the ACA marketplace. So this is it's a disruption kind of in both directions. If you're a big ACA player, this could be a tailwind. If you're a Medicaid managed care player, obviously it's a bit of a headwind. COVID subsidies expiration. We haven't heard too many folks talking about this yet, but after 2025, all the supplemental COVID subsidies that are afforded to folks enrolling in the ACA marketplace will likely go away, particularly if Congress is still split between Republican and Democrat. We can't imagine that those subsidies would be extended beyond 2025. And the ACA has enjoyed a couple of very robust years in terms of enrollment growth. A lot of that has to do with these supplemental subsidies, which basically go up to folks earning a couple earning $400,000 a year can still get a subsidy in the ACA. As that goes away, we would expect ACA membership to drop again. This is a big one. So you have the Department of Justice through the FTC, and of course you have Congress looking very, very closely at PBM economics. And PBM economics have really contributed a significant amount to carrier profitability over the last couple of years. I'll just give you an example. This was all comes from publicly available information, but Cigna talked about it gives 95% of its rebates back that it earns through Express Scripts, which is this PBM. That means it keeps 5%. That 5% that it keeps in rebates constitutes somewhere between 15 and 20% of the total enterprise, Cigna enterprise profitability. So if Congress or the FTC decides that rebates are going to go away, or they all have to be given back to the consumer or to the employer, that's going to represent a major potential hit to profitability for almost any carrier that has its own captive PBM, which are all the big ones today. The individual coverage HRA rule is starting to emerge. I think if for those of you who haven't followed this rule, basically what it means is employers can fund on a pre-tax basis now premiums for their employees to go out on the individual market. And some of the carriers are starting to report a lot of activity through the broker channels. Basically, it gives employers the opportunity to go from defined benefit to defined contribution, which is, as you can imagine, a big benefit to some employers. No one really did much with this during COVID. As you can imagine, employers didn't want to change their benefit design during a global pandemic. But now that we're out of that, we see that could have a lot of potential, and it could affect two segments again. If employers want to basically depart from the group model and just fund on a defined contribution basis, you could imagine commercial book shrinking. But again, a big tailwind, if you will, for the ACA marketplace, because it'll permit folks to go out into that marketplace on their own. And then lastly, again, price transparency rules. And we're not talking about the CMS one that impacted outpatient payment rule in particular. We're talking about the coverage rule that was a tri-agency rule between Labor, Treasury, and HHS, which required health plans to post, if you will, all of their negotiated rates for every provider for every procedure. Again, it's starting to get some traction, and we think it could have a significant impact on commercial and the ACA marketplace. It doesn't apply to Medicare and Medicaid, so it won't have an impact as much there, although it could have an indirect impact, as you could imagine. We introduced at the start, what does Wall Street think of all this? So it's interesting. All of the 6 major carriers this year, first quarter, elevated their guidance, their earnings guidance, and in second quarter either elevated or reconfirmed the first quarter increase in guidance. So current performance is very strong, but you see from this graph on the left-hand side, the 3 major indexes, on the right-hand side, the 6 major health insurers in the country, and they're going in opposite directions. And if you take what we talked about on that previous page and all of the disruptions coming from a legislative and regulatory perspective, there's just uncertainty as to how that will impact future performance. Again, if we go back and look at the FTC's kind of anti-merger stance, that could be another factor that impacts, if you will, growth through acquisition, whether that's vertical or horizontal. If you looked at the July 19th proposed guidelines that came out, really against any type of merger, if you look at it that way. So again, we think the street is a bit uncertain, maybe even skeptical about future performance, even though in general, the 3 major indexes are up significantly in some cases this year. So I'm going to hand it over to Shyam, but I think if you look at the bottom of the page here, what I've tried to address are regulatory and legislative disruptions. Shyam's going to talk about the potential associated with technology disruptions on top of all of this. So we'll spend a few minutes on that, and then we'll circle back and talk about the way ahead. Shyam?
Thank you, Paul. Very, very alarming indeed. So if I can move to the next slide. As if all of those challenges that, Paul, you highlighted were not enough, we have listed down a few more interesting trends, disruptive trends that we believe is truly bringing change in the market. And this is applicable both on the market business side of things, trends that we are seeing, as well as on the technology-enabled trends that you see on the right-hand side of this page. And one key thing to note before we dive into the details on each of these, historically in every industry, we have seen that it is usually multiple disruptive trends that come together to converge that essentially introduces industry sector changing impact. So we have some examples coming up later in the slide deck, but the convergence of some of these trends is potentially very alarming to existing incumbents. And starting from the left, I think there is a significant change to the focus that health plans or insurers have had to focus on the government markets. And Paul, you've mentioned this in the past. I think the growing business for most of them is going to be the Medicare Advantage market. It's a no-brainer today as we speak. It's an industry that adds $25 billion in top-line revenue growth year on year. And that by itself presents a significant amount of opportunities for every organization that is out there. But it also means a different way of working altogether. For example, health plans or insurers have traditionally grown in a B2B sales model. And with a focus on Medicare Advantage and the government markets, that is kind of transforming itself to a much more B2C business models. If you look at some of the regulatory impacts as well, for example, the weightage of member experience measures as part of star ratings, I think there is a significant shift in the workings. And every health plan, every insurer that is out there would do well to focus on transforming the business into a B2C business model. Now, one of the things that we've seen is, especially when you look at the digital experience investments on the technology side, to take a rough point of view or a provocative point of view, we have seen that a lot of the investments are a replication of existing processes in a digital environment rather than introducing a digital first experience into the healthcare industry. So, for example, even today, as compared to every other industry within healthcare, we don't necessarily see a consumer marketplace, a member experience community, or the moment the member moves away from your own app, your own member portals, you're essentially losing control of your memberships and so on and so forth. So that is something that every insurer will have to focus on. The next market business disruptive trend that we would like to highlight is the provider relationship. Again, with a shift to focus on the consumer centric business, consumers usually follow the providers as well. And what we've seen in the past is health plan or insurers have had a very or today with have had a very abrasive relationship with providers in sectors, and that is again something that every insurer or payer would have to focus on, especially through initiatives such as value-based contracts, partnering with the providers in a geographical region, and so on and so forth, to gain access to membership while also delivering value to that membership. Another key disruptive trend that we've seen, especially introduced post-COVID to a sense, is the alternative sites of care. And this is again a great example of how regulatory changes have driven business model disruptions. Back in 2018 or 2019, CMS made orthopedic surgery, they moved it from an inpatient only coverage to out of the inpatient only coverage schedule. And what has happened is post COVID, the overall volumes for orthopedic surgeries have come back to almost 100% of what it was pre COVID. But at the same time, the location of administering or provisioning of these surgeries have moved from an inpatient setting to outpatient and ambulatory surgery centers and so on and so forth. So the overall and the other thing is, within the inpatient setting, the surgeries that are continuing to happen is primarily the large chronic and complex cases, while the more profitable commercial orthopedic surgeries have completely moved out of an inpatient setting. Again, a great example of how a regulatory initiative have impacted business models and how organizations are thinking about it. Paul, you covered price transparency. I think overall, healthcare is perhaps one sector where the price of a SKU is not known to the consumer. And with the price transparency initiative, I think there is a definite focus to bring that to light. And we believe that the first couple of years around price transparency has largely been around regulatory compliance, but we will get to see the impact to business models, the impact to businesses on the ground over the next 4 to 5 years, and something that health plans, payers will need to be wary of. On the technology side of things, I already covered the digital first experience. But another interesting topic is what we internally call as stack integration. I think a great example of this is I think it was Jim Farley, the CEO of Ford, who went on a podcast and mentioned this interesting point of view, which is as Ford is moving away from an ICE car to a much more digitally enabled electric vehicle. One of the things that Ford realized was they had about 150 odd suppliers building solutions or products for their particular car. And it was becoming very difficult for them to digitally enable that vehicle. And if you look at it, most of the healthcare organizations, payers who have grown through acquisitions, have procured multiple different technology investments over the years. And to truly move towards a digital organization, there is significant stack integration that needs to happen, because if you're not in a seamless technology stack, your ability to innovate on top of that continues to be challenged. The next item over here, which is AI and AI enabled thing, I think obviously with the OpenAI initiative and the generative AI buzz that has been going around, this is the market buzz as we speak. We believe this is only a starting point within the industry right now. And over the next 4 to 5 years, AI in general across all industries is transforming itself to a multi-trillion dollar market. Within healthcare, I think there are many notions of impact of AI to healthcare. If you just focus on one of them, which is the improvement in knowledge worker productivity across all kinds of knowledge workers, not just technology, but clinicians, and how aiding clinicians in their day-to-day stuff, operational improvement, the overall productivity improvement is one big factor that could drive optimization and the change in the market itself. Uh, the last point, again, proprietary data. I believe it was John Halamka who recently mentioned that by 2030, almost all healthcare organizations would largely be organizations that produce data, and the innovation would depend on how well you are able to label your data, process your data, compute your data, and leverage or deliver insights out of that data. And that is a key focus for innovation. And as payers move through the next 4 to 5 years of industry change, ensuring that you are taking care of your data and labeling it appropriately, etc., is going to be a significantly important focus area for payers. The next slide is a summary of how we think, or it's a historical representation of how convergence have truly disrupted the market. So right across all of the variety of different types of industries that you see, that has been disrupted over the last 100 years. There are a few key points that every insurer, every payer should keep note of. One is the point that I mentioned earlier. Disruption usually happens as a result of convergence of multiple trends, multiple disruptive trends coming together to introduce sector-changing impact. We've seen that in the past with the internet, with smartphone, and so on. A key point to note is if you look at almost all of the disruptions that have happened in the last 100 years, it has largely been done from the outside, where an external organization has come in and disrupted the incumbents. That's not to say that will happen in healthcare as well, but it's definitely something that we all should be wary of. Uh, the third important point is each of the disruptive trend has uniformly followed an S-shaped adoption curve. So typically we tend to extrapolate everything in a linear fashion because that's how we are used to projecting items. But every disruptive technology, once it crosses the point of or a specific threshold, has been adopted in an S-shaped curve, and that is again something that we should be aware of. And finally, one last point is, if you move on the graph, if you look at from the left hand side to the right hand side, you would also notice that as technological advancements have progressed, the duration or the rate of change of disruption has accelerated as well. So you would see much steeper S curves towards the right as compared to what you could see on the left hand side. Again, we believe, as far as insurers are concerned, there are multiple converging trends that could potentially introduce disruptive changes in the market, and that is definitely something that payers should focus on. Moving on. In summary, Paul, you may want to take this slide in terms of what are some of the recommendations and thoughts that we have on taking this forward.
Yeah, so we just thought we'd offer a perspective on, okay, how do you want to start to think about responding to these disruptions? And I think the overall message is that whether it's the government, the consumer, potential competitors, you're coming after your margins, right? So from a regulatory, from a legislative perspective, again, we didn't talk too much about competitive intensity in the MA segment, but the number of new plans, the number of expanding geographies that incumbents have. So it's clear that there's a bit of a crosshairs on the margins that the large carriers are making. And I think that's what, going back to the DOJ and Congress and PBMs, I think that would be the epicenter, if you will, of that. So what are some of the implications, I guess? There's a big productivity imperative, certainly in the administrative functions, and I'll let Shyam talk a little bit about how AI and some of the other tools might be able to accelerate that. But that'll be important as not only as the technology emerges, but as the constraints on margin from some of the other forces at work become more prominent. We believe that there is a big opportunity here, and that is, you see the second point, which is changing provider behavior. A lot of this is value-based care. We would encourage you to think about, and many of you already are, the whole person platforms that you're developing and so forth. To the extent you can impact through the providers and through the right incentives, lifestyle induced disease, social determinants of health. Obviously, we have a healthcare system that is focused on cure, not on prevention, and we've heard that for decades. This will become more important, again, to sustain margin and so forth, expand the reach into some of these areas that are just now emerging. And then even, how do you guide members? So if you think about this, we want lower administrative costs. We want to prevent or inhibit unnecessary demand for services, which is the second point. The third point is, you certainly can't eliminate all demand for healthcare services. So when it is necessary, how do you guide the patient, if you will, to the highest value provider? And that's not just price, it's obviously quality and outcome and so forth. But the transparency and coverage rule that we talked about a little bit earlier is a big empowerment opportunity to do that. So just at the highest level, productivity improvements at the admin, really designing value-based care programs that prevent unnecessary demand for healthcare services. And then when healthcare services are necessary, ensure that the consumer, the patient, is going to the highest value provider. All three of these are sources of value creation in a world where regulatory, legislative, and technology disruption is emerging. Shyam, do you want to talk about the right-hand side a bit?
Yeah, absolutely. In terms of the impact itself delivered by technology, there was a question that was asked as well. How does prior authorization, how does that get impacted? using some of the new technology, EHR integrations, etc. So interoperability has been a significant challenge over the years. Prior authorization takes about 20 to 25% of healthcare cost today as we speak. And there are opportunities to automate that by itself. So, for example, starting from simple low-hanging fruits, summarization, documentation, clinical documentation, etc. There is always ability introduce optimization or productivity improvement on that front. That's a great example of how advanced analytics, generative AI, and similar capabilities can contribute to reducing the or improve reducing the cost while improving the productivity of administrative functions. Value-based analytics. I spoke about the provider abrasiveness a little while back, but I think overall it is extremely important for payers to understand the provider performance. Value-based contracting has been around for a while, but it is also one of the primary things that is disrupting the cost or the pricing impact in the market. And understanding a provider, meritocratic steerage of members to the right providers, while ensuring that risk transference is happening across your contracts, as well as monitoring your providers through enterprise analytics for value-based care, etc., are going to be extremely important initiatives that payers would need to run. And finally, the impact to members by itself. I spoke about the digital experience, but introducing tool sets across price transparency for members, enabling members to take the right decision or choice through tool sets that are made available to them, are all going to be an extremely important thing. And we believe technology will drive a lot of those changes or transformation.
Yeah, and just to add, I think, while not 100% overlap, if you take the three items on the left-hand side, they map pretty closely to each of the three items on the right-hand side. And if you go back to what Shyam said just a couple of minutes ago about the convergence of various forces at work that lead to major disruptions, I think what we're trying to assert here is there's a potentially a new set, or certainly a heightened set of imperatives for carriers to address the three things on the left-hand side. Well, there's technology solutions for each of those three that are emerging. And if you can really make those three work, that apply technology on the right-hand side to the items on the left-hand side, we think it's a reasonable hypothesis for a way to reconcile all this and really return to a steady state of profitability. Shyam, I think that's all we had in terms of the formal piece of this. Do we want to open it up for questions now?
Yes.
All right. Well, that was great. Thank you. We can move on to the Q&A now. As a reminder, you can still submit questions using the Q&A tab to the left of your screen. I see we have a lot of great questions already. We will try to get to as many of them as possible. Let's begin here. First question. In what ways do you see prior authorizations and the modernization of that process, EHR integrations, helping payers' future business models?
Shyam, do you want me to start with that?
Yeah, I kind of covered the technology aspect of that while I was answering the administrative improvement. Paul, if you want to take the business model impact, I think that would be great.
Yeah, I mean, it's from a provider perspective, this is obviously a real nuisance, and in a number of ways. One, administratively, just going through the process of trying to get a pre-authorization is not easy. But I think also it is a bit of a, if you will, an assault on a physician's kind of prerogative and knowledge, or at least that's the way it's perceived, right? I have a mixed point of view on this, having been at CMS for a while and working in the Center for Program Integrity and looking at, I'll just give you an example, electronic wheelchairs or electric wheelchairs about a $30,000 purchase. When we put in a pre-authorization for those in Medicare, the demand for them dropped by 95%. So what does that tell you? So I think pre-authorizations selectively used, particularly where there is a broad variation of clinical practice that's inexplicable, is probably a good thing. The question is, and maybe Shyam can address this as well, as we really introduce advanced analytics to understand, kind of standards of care and clinical standards of care and variation and so forth, how can we introduce that into the provider community in a way where the variation and how physicians treat patients is reduced significantly, and therefore the need for pre-authorization is reduced. One other thing I know that some carriers experiment with, I think, is a good practice, which is they monitor physicians over time, and those who really do adhere to the clinical standards of practice, they put them in a category where they don't have to use pre-authorizations for those docs. And for the ones who, let's say, are not as adherent to the clinical standards of practice, you continue to do it. So you're really rewarding those who are practicing at the highest standards, and you're continuing to monitor through pre-authorization those who don't. But Shyam, do you want to add anything?
Yeah, absolutely. So in my mind, there are three things that we should focus on, and the impact across each of those things. There is ability for technology to impact each of those things. One, I think, I don't remember who said this, but I think we should not be trying to optimize something that is not required. So at least from the 20-25% spend that healthcare is seeing on prior authorization, I'm sure there are, to Paul, to your point, based off of repeatability, the rating, the risk rating that you may assign to a provider, etc. I think there is probably ability to do away with 10 to 15% of those authorizations itself, which could in itself become a significant impact. The second thing that I would say is, if you look at prior authorization, you can actually split it across multiple different areas or categories. So orthopedic may work in one way, radiology may work in another way. And the objective of some of the impact of AI, generative AI or small language models, etc., in this space to optimize or improve the productivity in this space is going to be extremely important. And the third thing is the automated interoperability between payers and providers, which has been, I think, overall, if you look at the last 10 years, the maturity curve on that one has been increasing steadily, maybe not at the pace that everybody thought it would. But definitely, if you look at what has happened over the last 10 years, there has been a slow, incremental, positive focus on that front. So I think those three things coming together over the next few years could definitely alleviate a lot of the concerns on the prior authorization side.
All right. Next question. Technology can help reduce administrative burden across the healthcare value chain, but while promising reduction in cost, can it also improve health outcomes?
Yes. So I think there is a notion that technology will completely help solve for health outcomes, which is probably a few decades out. But there is always an opportunity to improve health outcomes. So without technology, how do you do meritocratic steerage of members to the right providers? Without technology, how do you monitor the performance or the quality of care that is being provided over the years? So I believe without technology, how do you ensure real time point of care clinical decision support, or how do you aid that? So definitely, while there are low hanging fruits on the administrative burden, which obviously is going to impact or optimize the performance of an organization, from a clinical outcomes, health outcomes perspective, we already see significant evidence of improvement on that front. and that by itself is only going to increase over the next few years.
I would just add, I think to have a slightly provocative point of view, I think the way technology is going to improve outcomes is by empowering the consumer and empowering the patient. One of the things we did, if you remember, at when I was at CMS, was require providers to, if you will, populate consumers or patients' electronic housing area for medical records and that type of thing, so that individuals can own, if you will, their own medical records for the first time. If you look at some of the remote monitoring devices and iWatches and all that other stuff, there's an immense amount of information now that's in the hands of the consumer that the physician doesn't even necessarily have. And if you combine that with clinical medical records, if you combine that with the individual probably knowing more about their family medical history and a few other things, I think as we go forward, there's not going to be anyone in a better position other than an informed patient or consumer to, identify when something is not right, or to be able to tell the providers this therapy is working or it's not working or whatever. So I would anticipate a shift, if you will, from a lot of this technology, a shift in terms of knowledge and information, much more into the hands of the individual, and used properly, obviously they can have a significant impact on outcomes.
All right. Moving on. Why have new entrants in the market struggled, for example, Oscar or Bright Health?
Paul, do you want to take that?
Well, yeah, those are two very different situations. So I'm not sure I would cluster those two together. I would say a couple things. One is, if anyone's looked at Oscar lately, they're actually doing quite well. I think they reported this quarter, for the first time, they've achieved profitability. Obviously, they hired Mark Bertolini, one of the probably the most accomplished executives in the health plan sector. So they're doing quite well. I think they got themselves in trouble when they expanded out of the ACA marketplace, which was their core competency, and their core market segments, which were tech savvy individuals who wanted to deal in a pretty frictionless way with the healthcare system. When they expanded much more into Medicare Advantage, a different demographic, different level of tech savviness, totally different key success factors, things like stars, they didn't do as well. And of course, they've pulled back and now doing well again. I think the second thing is, as a lot of carriers understand, you need to have a fairly significant presence in a given market to have influence over the providers and to amortize costs of advertising and enrollment and those types of things. Again, if you look at Oscar, its core, one of its core markets is the tri-state area of New York City, doing quite well there, not as well, in maybe some of the distant geographies. On Bright, I think it is, I don't know as much about them, but, Clover's having some issues as well, although they seem to be improving. What I would say is this: Medicare Advantage is an extraordinarily sophisticated field with the key success factors requiring a lot of capabilities and a lot of depth of knowledge. So a large carrier might have 30 or 40 individuals, experts dedicated just to maintaining stars. If you're a United or a Humana with 5 million plus Medicare Advantage members, you can do that on a cost-effective basis. If you have 50,000 members, you can't do that. So Medicare Advantage is much more of a capability-led game, and that capability requires a lot of specialization of labor, which requires a lot of investment. And if you don't have critical mass, if you only have 50 or 80,000 members, it's very difficult to amortize the cost of that. So I think the barriers to successful entry are actually higher in that. And there's also not to ramble on here, but there's what we're seeing in Medicare Advantage is both virtuous and vicious cycles. If you're a 5-star plan, that you can, use some of that economic surplus to invest in supplemental benefits and buy downs of Part B premiums, and you go to the market in the annual election period, you're going to be more attractive, and you're going to grow faster than someone who's a 2 or 3-star plan on average that doesn't have that and can offer the same, if you will, benefits. So that's the difference between a virtuous and a vicious cycle. And I think we're seeing that now, and some of the carriers are going into 2024. They recognize that, and they're going to quote invest in acquiring members in 2024 to try to offset that more vicious cycle. So, I mean, that would be my explanation. Again, I think Oscar's in a totally different position than Bright was, given the segments they're serving and given their histories. Shyam, I don't know if you wanted to add anything to that.
No, I think you covered it, Paul.
Okay. The next question. What is the outcome from DOJ congressional scrutiny in PBMs?
Yeah, it's interesting. Gosh, if I had the answer to that, I'd place some investments right now. But I mean, I think there's puts and takes to it. If you noticed in the last couple of quarters, all of the senior executives on the earnings calls have been, it's a little bit of, Lady Macbeth protesting too much, right? Oh, PBM's creating a lot of value, unsolicited. That a lot of comments about the industry can't do without PBMs, and we're creating a lot of value for the consumer and that type of thing. So a bit of a defensive posture there. Obviously, pharma, the lobby group, is very powerful in DC. We've been down this path before, and Congress never really flips the switch on some of these things. So I don't want to predict, but I think what I will say is that the American people and a lot of health insurers that don't have their own PBMs are worried most about the lack of transparency. And I think that's what's hurting the PBM sector right now. Is it seems like a black box, and how come they're not being more transparent about it? When I was at CMS, our biggest concern was twofold, two big concerns. One is we saw the incentives through the value chain, which includes the PBMs, were to use more expensive drugs in higher volumes. And there was a thing called a rebate wall, which precluded some generic drugs to get on PBM formularies because they couldn't offer anywhere close to the same rebates. So if you think about that conceptually at a national level, not if you're a PBM owner, that's not a good thing to encourage the system to unnecessarily use more expensive drugs in higher volumes. The second thing we were concerned about was that if you think about seniors who have co-insurance for pharmaceuticals, they're paying 20% on basically, I don't want to say list price, but a price that's much higher than the price after rebates. So the seniors, out-of-pocket expenses, they were not getting the benefit of the rebates. And you could say, okay, Paul, but that permits us to offer lower premiums, so aren't they getting the benefit there? Well, yeah, maybe, but not for the ones who are heavy drug users, who have a lot of needs, chronic diseases and so forth. So I think that has become, those two issues have become the basis for why there's so much scrutiny within the PBM community, and it's exacerbated by the fact that there's a lack of transparency. So I think this is going to continue. It's kind of bipartisan, if you will, meaning even in our administration, Secretary Azar, if you remember the rebate rule that was finalized right before we left office, not implemented, but finalized. He was concerned about that. We were concerned about it. And I think the current administration is concerned about it. So who knows where it'll wind up, but I think the scrutiny will be there for a while.
Okay, moving on. You mentioned inability to scale post-acquisition. What are the root causes behind that?
Yeah, it's well, I'll give you some statistics, and these are great companies. Let me start with Humana. Humana's open enrollment success has been spectacular. I think they reported this quarter that they'll increase their membership by 825,000 members. They also have, through CenterWell, they have a series of owned captive primary care clinics. I think it's somewhere around, it's a couple hundred clinics, and they're growing those clinics. And they reported that the growth in those clinics of their own members using those clinics this year will be 25,000 individuals. So what you see is the membership enrollment success is so much faster and so much greater than getting individuals to use their captive clinics, that there's even a growing divergence, if you will, between the alignment of captive providers and captive members. Why is that difficult to scale? Well, think about it. First of all, there's a brick and mortar aspect of this. You actually have to either build or lease and outfit the clinics, but you also have to attract physicians away from whatever they're doing today. We don't have a surplus of physicians out there. A lot of them are employed by hospital systems. A lot of them are in their own groups. So how do you actually staff those clinics and scale that model? And you could say, okay, well, why don't we just take, I'll just use another example. Why don't we just take Oak Street's analytic model and scale it over independent practices? Well, that's easier said than done. That's disruptive. And if you think about it, if you take a primary care practice and you say, how many of their members are from any single carrier, it's a very small amount. So why do I want to install an IT system overlay for what might be 5% of my members as an independent practice? That's a huge disruption for something that's maybe not a big economic gain. So I just think it's going to be a challenge, and each of the major carriers, as they acquire providers and primary care practices and home health agencies, they've said they're going to be payer agnostic, meaning they're going to take all insurance company payments. Well, they have to do that. They have to do that, or there's not enough critical mass even to service the acquisition of the assets that they've made. And we actually think that's a good strategy. And I don't want to diminish, if you will, this combination of pharmacy, primary care clinic, home, integrating all of those in a way that prevents unnecessary hospital admissions, readmissions, emergency room visits, increases adherence to drug regimens. It is leading to lower costs. So it is an effective model for lowering costs. It's just that all of those lowered costs are not accruing to the carrier that owns them. In fact, it's a distinct minority. I haven't read anything of anyone expanding that alignment more than 20%, meaning if you look at medical loss and you say how much of that medical loss flows through my owned captive providers, no one is above 20%. So 80% is going to other providers in the network. So it's just it's a very difficult thing to scale. And when I say scale in an aligned way, meaning we're scaling it so that we can get more of our own members going through our own providers. And I just don't see that working long term.
One reason why national plans may not be seeing benefits from their investments is inability to integrate disparate assets. If that's true, what steps can they take to successfully integrate?
Yeah, well, there's a lot of aspects to that. Let me offer a few, but I think there's also some technology aspects that I'll let Shyam address. There's no performance management system. So if you're treating these as business units and they all have to stand, quote, on their bottom lines, sometimes dealing with independently or in silos permits them to move more quickly, make them, they're more nimble. And in some cases, they actually get higher reimbursement. I mean, this is the real challenge with what I call bilateral open IDNs. sometimes as the carrier, you have to maybe reward outside providers, give them higher reimbursement than you give your own captive providers, and vice versa. Sometimes there's other health insurers that are willing to reimburse your providers more than you are. And why not? If I'm responsible for a bottom line as a business unit leader, I'm going to favor where I get the higher reimbursement, for instance. So a lot of this has to be in performance management systems on how the large carriers do it. I think there's other complications as well. I think some of it is cultural. And I'll just give you an example. Health insurance has largely been a white collar business the last 80 years. Hasn't been a frontline care delivery business with housekeeping and with patient transport folks and so forth. So you actually have, some cultural clashes that need to be reconciled as well for, all of those different components to work as a team. So those are two more organizational factors. Do you want to just address real quickly, Shyam? I know we only have a minute, but some of the technological challenges.
I think we are running out of time, but overall, I think from a technology perspective, how do you transform something that is already in flight? And as you can imagine, all of these organizations have made investments in technology. They have grown through acquisitions. There is significant tech debt that is already in place that is required to be alleviated to truly integrate with one another. So the ROI on some of that is definitely a challenge, especially with a cap on the investments that you can make on a year-to-year basis. So obviously we can get into the details in terms of which technology, which area, what are the specific challenges. But overall, I think to summarize on this specific questions, it just boils down to people, process, technology, and culture in some ways.
Well, thank you both so much for this. And thank you to the audience for attending this Fierce Healthcare webinar, submitting so many great questions. I'd like to thank our speakers again for participating and Citius Tech for presenting today's webinar. A recorded version of the webinar will be available for you to access within 24 hours using the same audience link that was sent to you earlier. Thanks once again for joining, and we look forward to seeing you at future events.